Yes.
Yes, sir.
Thank you. Okay, so it's 7 o'clock. Good evening, everyone, and welcome to the second part of the 10th masterclass on anastomotic leak. So those who are joining us today, those who would be watching it for the first time, Jaipur Masterclass is an extension activity of the Jaipur Surgical Tutorial, which is an online surgical education portal that we started here in the Mahatma Gandhi Medical College and Hospital 3 years ago. JST is being looked after by my colleague, Dr. Anand Nagar, who's an associate professor in HPB surgery. So two extended activities of JST. One is the masterclass, which we hold every last Thursday and Friday of the month, 2-hour session on each day. So 2 into 2, 4 hours, a single theme. In the previous classes, we have covered living donor liver transplant, safe cholecystectomy, acute and chronic pancreatitis, intensive care, ulcerative colitis, liver SOL, and some other topics. And we intend to continue this every month. And then, because the Jaipur surgical tutorial is Saturday morning, 9 to 10, but then some of the students and surgeons from Africa, they wanted a separate session or an additional session because that time was inconvenient for them. So a few months ago, we started a Friday afternoon, 3 to 4 p.m. Jaipur Surgical School, which is mainly targeted to them. Now, in most of these activities, as has been the trend in the recent past, the live online attendance is not much. But what we have seen that the views of the videos which are uploaded by the team of Dr. Avinash Nag in Ahmedabad, Dwarika Clinic, they are quite encouraging. In fact, today only I've updated the number of views of the previous master classes on various groups. And some of the master classes have had 500 and some have had even 1,000 views. So that makes us happy and satisfied. And I would request and urge all the faculty colleagues to continue to contribute to these online educational activities. So we covered some aspects of anastomotic leak yesterday. And today, the sessions will be moderated by Dr. Sastry, who is one of the senior most GI surgical colleagues in the country. He had a long stint at the Nizam Institute of Medical Sciences, and currently he is at the KIMS in Hyderabad. And he will be joined very shortly. Dr. Das just messaged me that he will be joining in a couple of minutes by Dr. N.R. Dash, who is the professor of GI surgery at the All India Institute of Medical Sciences. And we have 3 speakers today, and then we will have an half-an-hour open house session. So with that, I hand over to Dr. Sastry. Dr. Sastry, maybe you can start and Das will join.
Yeah, sure. Good evening and welcome to the second day of the GI Masterclass. Let me first compliment Dr. Vinay Kapoor for this great initiative of his in conducting masterclasses on some practical subjects in GI surgery. And thanks for inviting me to be a part of the latest on anastomotic leaks. We did have some wonderful exposure yesterday to some of the aspects of anastomotic leaks, the techniques of anastomosis, the risk factors, and some specific leaks like esophageal and small intestinal leaks by reputed speakers and moderators. Today's session is devoted to the other specific leaks like colorectal anal anastomosis and the problems associated. Although there is some commonality among various anastomosis, there are specific problems for the distal anastomosis. And historically, a diversion stoma has been a part of lower rectal anal anastomosis. And it is expected to serve two purposes. One, to divert the fecal stream away from the site of anastomosis. And two, to minimize the impact of an anastomotic leak if it occurs. Now, while a stoma does mitigate the clinical impact of an anastomotic leak, it comes with its own risks. That is the stoma-related complications. Now, we have Dr. Vaibhav Varshney from All India Institute, Jodhpur, to address these issues. Is it mandatory to have a diversion stoma in all the anastomosis? And if you have to have, what type? Ileostomy, colostomy, or any other? And a risk-benefit analysis of these. I think you would be addressing these issues. Dr. Vaibhav Varshney, please.
Thank you, sir. I would share my screen first.
So while Vaibhav's slides are coming up, let me say that Vaibhav is one of the young GI surgeons who's leading a very excellent team of young faculty colleagues at AIIMS Jodhpur, and they have recently acquired a robot, and they have presented and published their experiences with robotic surgery. Vaibhav.
Thank you, sir. Thank you, Professor Kapoor, for giving this opportunity to present on this topic of proximal stoma in LAR. And thank you, moderators. So I'll start my talk, sir. Am I audible, sir?
Yeah, very much. Go ahead, please.
So the topic is whether, when, and which stoma in LAR, as Professor Sastry just briefed it. So nothing to discuss for this presentation. So why we are discussing why we need a stoma after low NT resection? Because the most dreaded or life-threatening complication of LAR is anastomotic leak. Its incidence varies from 0 to 20% because of the varied definitions for the anastomotic leak. So there are various preventive strategies which we use intraoperatively and preoperatively to prevent this complication. So one of the complications is preoperative mechanical bowel preparation, oral antibiotics. When we talk about colonic surgeries, this role is still dubious, but for rectal surgeries, yes, mechanical bowel preparation and oral antibiotics play a role to prevent the anastomotic leak. Second, intraoperative testing the anastomotic integrity. Like we do jacuzzi test where we put the patient in reverse lumbar position, pour saline in the pelvis, and with the help of Tomy syringe or normal syringe, we just push the air after clamping the proximal colon to see whether there is any air bubbles present or not. And then the perfusion study, which we usually doing nowadays, very popular with the help of endocyanine green, to see whether there is any ischemic zone present or not. If it is there, we revise the anastomosis and then do it. Then few surgeons also prefer to do anastomotic reinforcements and buttressing, taking even after doing a septal anastomosis, take some sutures at the corners to prevent the anastomotic leak, and then avoid crossing the staple lines. Creation of colonic J pouch. This means when we are doing a end to side, end of the rectum or canal and the side of the colon. That is done because they mention that the side is more vascular and there is a less tension on the mesentery. That helps in prevention of anastomotic leak. And the last is defunctioning stoma. So now we will discuss whether actually it is decreasing the severity of leak or it is actually helping decreasing the incidence of anastomotic leak. So as we discussed yesterday also, there are various risk factors of anastomotic leak after LAR. So there are preoperative, intraoperative, and postoperative. And apart from this, they can be modifiable or non-modifiable. So in non-modifiable set practices are smoking and alcohol consumptions, which are, if the patient is a chronic smoker or alcoholic, there are risk of anastomotic leakage. So we need to advise these addiction to stop before surgery. Then obesity and malnourishment, if the patient is having low BMI, low hemoglobin, less albumin, then the patient is at risk of anastomotic leakage. Then if the patient has preoperative chemoradiotherapy, again is a risk factor for anastomotic leakage. Then the vascularization of the digestive segment, as I mentioned, the indocyanine green, which can be used to see whether the bowel segment is well vascularized or not before contemplating the anastomosis. Now, second is the type of anastomosis, like whether we are doing it by hand sewn or by stapled. Mostly circular stapler is utilized. And when we have seen the literature that diameter of circular stapler has no bearing on the anastomotic leak, it is the gradual compression and firing in a proper manner is important to prevent the anastomotic leakage. Then laparoscopy has an edge over the open surgical approach in the prevention of anastomotic leakage. Prophylactic pelvic drain, some says that if there is a drain placement, there is a fluid collection there that can act as a medium for the bacteria to grow and cause anastomotic dehiscence. So putting a pelvic drain is sometimes useful, but the evidence is still debatable. Then diverting stoma, which we are going to discuss further, and the blood transfusion. If there is an intraoperative blood loss, this could be a risk factor also for anastomotic leakage. Now coming to the non-modifiable risk factors, male gender, if the patient is having comorbidities, ASA score of more than 3, again, very important factor is distance of tumor from anal verge. If it is a low-lying tumor, near to the anal verge, less than 5 centimeters, this is again a risk factor for anastomotic leakage. And then if we are doing the surgery in emergency settings, if surgeon experience is less and the intraoperative timing has increased because of various reasons like difficult anatomy or a low-lying tumor, multivessel resection. So this could be a reason for anastomotic leak. Why we are discussing all these factors are because based on these factors, we are going to take a decision. The first question of this topic is whether to do the stoma. So based on these factors, we are going to decide whether the stoma is required or not. So the next stoma is why we are discussing just make a stoma or don't make a stoma, because both the procedures, like if we make a stoma, it is again a morbid for the patient and reduces the patient's quality of life. And if we don't make the stoma and the patient's anastomosis leaks, again, this is going to cause problems to the patients by reducing the quality of life and other factors in terms of long-term survival. So if we make a stoma, so what is going to happen? The leak is become controlled, though it does not decrease the risk of leak, but the need for urgent reoperation decreases. And if we make a stoma, the problem is there is a need for second surgery. There is a longer hospital stay. And as our Sastry mentioned, it comes with stoma-related complications like stomal necrosis, stoma prolapse, stoma-related skin excoriations. So this the patient has to bear. And then complication after stoma reversal, it is noted with wound infection, small bowel obstructions, and hernia at the surgical site. And in some cases, it has also been noticed that stoma cannot be reversed despite being temporary. So making a stoma is not just a simple decision. If you don't make a stoma and there is a no anastomotic leak, the patient is the happier one. There is no need for second surgeries. Patient can go home in a very short span, a very short hospital stay, and we can start the adjuvant chemotherapy very soon. But if there is a leak, yes, there is a risk of leak rhipidotomy, a stoma formation, percutaneous drainage to drain the collections, and then other measures for healing of the anastomosis like endosponge therapy, transanal tubes, and there are many. So when we saw the meta-analysis, we have found that you can see the diamond is favoring the divergent stoma. So in both anastomotic leak and reoperation. So they say that, yes, when you do a protective diverting stoma, anastomotic leak helps in decreasing the anastomotic leaks and the reoperation rates. Further, if you see that after doing a divergent stoma, the anastomotic leak and reoperation rate are less in the no divergent group. This is contrary to the last study. So, but if you see the survival benefits, it has seen that if the patient has anastomotic leak, the long-term survival has significantly increased. But if you have done a stoma or without stoma, the long-term survival is similar. So this study favors that if you are doing a stoma, the survival is similar. And if there is an anastomotic leak, it will lead to decrease in the long-term survival. Now, the question again, does a stoma reduces anastomotic leak rate? This study, a meta-analysis of RCT have mentioned that yes, diverting or defunctioning stoma after LAR reduce anastomotic leak and reoperation rate, as I mentioned earlier also. Further, this study from Japan and other center, they are contrary to this note that divergent stoma did not reduce anastomotic leakage, but increase in the risk of post-operative intestinal obstruction. So there are both pros and cons of making a stoma. So then how to decide upon? So there is another meta-analysis of RCT from India by Dr. Pankaj Garg from AIIMS Rishikesh. He have taken 5 RCTs for this analysis, and then they concluded that divergent ileostomy in LAR for rectal cancers decreases the anastomotic leak and reoperation by 1/3 anastomotic leak and 1/4 in case of reoperation rate. So making a stoma is beneficial. Another recent meta-analysis on the same topic, the second question of our theme is when is diverting stoma is indicated from the Dr. Wexner's group. They mentioned that with diverting stoma, the complication rate is low, anastomotic leak, abscess, and reoperation is less in the diverting stoma group as compared to no diversion group. But both groups are comparable in terms of bowel obstruction, surgical site infection, and perioperative mortality. But the other factor is the mean operation time in the diverting stoma was longer than no diversion group, as obvious, because it takes time to create the stoma. So they mentioned that the factors that significantly associated with anastomotic leak in non-diverted patients were high BMI, around more than 35, ASA more than 3, low tumor height, I mean that tumor near to anal verge, patient who have received neoadjuvant therapy, open surgery, end-to-end anastomosis, and longer operation time. So they concluded that when these factors are present, so the question is when to make a diverting stoma. So if the patient is high BMI, high ASA, low rectal tumors, neoadjuvant therapy, open surgery, end-to-end anastomosis, long operation time because of any other reason. So it is better to make a divergent stoma. So just to conclude this, when to and whether to make, if these factors are present, male patient with high age, less than 5 centimeter tumors, neoadjuvant therapy, unprepared bowel when you are doing the surgery in emergency settings for obstruction or perforation, longer operative time, intraoperative blood loss, any issue with stapler malfunction or any technical issue you have encountered intraoperatively, like positive air leak test, multivessel sections, or if patient is malnourished in the preoperative period, it is better to divert the fecal stream. Otherwise, if the anastomosis leaks happens, it is going to be very morbid for the patients, and diverting stoma will decrease the severity of anastomotic leak if it happens. So now, which stoma to make? So we have option of loop ileostomy or a transverse colostomy because the descending colon has already reached to rectum for the anastomosis. So there is no demandable superiority of one procedure over another. But in terms of complications like stoma prolapse, wound infection, and time span of stoma reversal is less with loop ileostomy. However, as obvious, the ileal effluents are liquid and the stoma output will be more in loop ileostomy group as compared to transverse colostomy. But when the patient is have marginal renal functions, so colostomy is preferred because the stoma output is more in a semi-solid state and there will be less fluid loss as compared to loop ileostomy. So there is a comparison head-to-head, and they found that loop ileostomy has low rate of leakage, wound infection, stoma prolapse, and bowel obstructions compared to loop transverse colostomy with more wound infection, bowel obstruction, and stoma prolapse. So as compared to conventional ileostomy, there are two options they have suggested to decrease the stoma-related complications, like doing a ghost ileostomy or a virtual ileostomy and a temporary percutaneous ileostomy. In ghost ileostomy, what is done is you just need to make an opening just close to the bowel into the mesentery and take this sling out at one point. So the patient leaks in the post-operative period, then you need not to do a full laparotomy. You just open this side and just take out the ileum through this side. So will prevent the re-laparotomy in the post-op. There is an ongoing trial, RCT is going on this topic, but there are a systematic review and meta-analysis on the retrospective study that compared ghost ileostomy versus loop ileostomy, and they have mentioned that the GI versus no stoma compared to they have less incidence of anastomotic leak, and the complication grade A, B, and C are all less with GI. So GI with low anterior sections have no increased risk of anastomotic leak or post-operative morbidity compared to conventional loop ileostomy. So it's a feasible technique to prevent stoma-related complications and adverse effect on the quality of life. The other option that present is temporary percutaneous ileostomy. This is a feeding tube of 20 French to 18 French is placed in the distal ileum, 40 centimeter proximal to ileocecal junction, the site where we usually choose for loop ileostomy. This catheter is fixed to the ileal loop. And between 8 to 9 day post-op, they did a CT scan and there is no leak, then they just remove the catheter. So they found that the overall hospital stay and cost difference was significant. And they have mentioned that it is advantageous more in the elderly patients to prevent limited duration, to do a limited duration of fecal diversion. And there are different types of defunctioning ileostomy, which is mentioned. One is the standard loop ileostomy, one is a skin bridge. The second one is skin bridge, where they don't remove the whole skin from the abdominal wall and just leave from a rectangular patch stuck to one side, and then this skin bridge is used at the cross to the mesentery and help in stomal retraction. Then one is umbilical ileostomy, and then other method, as I mentioned, transical ileostomy, percutaneous ileostomy, and a cannula ileostomy. So to conclude my talk, anastomotic leakage, as I mentioned, is a life-threatening complications after LAR. So divergent stoma, yes, it decreases the severity of anastomotic leak and reoperation rate. So divergent stoma should be considered in patients who were at high risk of anastomotic leak. As I mentioned, all those risk factors we need to have in our knowledge when we are doing the surgeries, both pre and intraoperatively, and based on those factors, if these are present, make a diverting stoma. If they are not, then we can avoid the diverting stoma. And diverting loop ileostomy is better to transverse colostomy in time of decreased time to closure and stay in the hospitals. Ghost ileostomy and percutaneous ileostomy are options which can decrease the stoma-related complications. Thank you, sir.
Dr. Sastry and Dr. Das.
Dr. Das, you want to say something?
Das, you want to come in?
Yes, sir. I just 5 minutes late as coming back from OT just now.
No problem.
So, Vaibhav, I think, sir, he has covered everything. We had, I think, last JST eighth version, we discussed about it, of course. And this was more extensive and you covered the evidence part very well. I don't have to comment anything on the evidence or what you said, because what you practically said is better go for a stoma when you are doing a low anterior resection, isn't it? That's what is coming out of the literature. Now, what is my practice after the experience of maybe about 20 years is first I look at for what I'm doing the low anterior resection, benign or a malignant lesion. So benign for polyps, suppose I am doing, and happy with the anastomosis, I don't do any stoma. Now, there are two studies to say that if you put a per rectal catheter, soft catheter, across the anastomosis, that decompresses the air if the bowel has been prepared well, decreases the pressure in the anastomosis, and might be helping. So over the last 10 years, I have only one leak for low anterior resection and not ultra low anterior resection. If I'm doing ultra low anterior resection, I do a stoma always, and always a ileostomy and loop ileostomy, which has proved to be better. But if you see, follow up these patients, the loop ileostomy is not a permanent or not a end ileostomy or a permanent type ileostomy. They do come back to you after a few days, some of them, that I'm passing some amount of motion down. So there is a continuity downwards. So I would say that if you are happy with your anastomosis, you can see it all around and it's healthy, then we can go ahead without a stoma. If it is a malignancy, now the question a little bit varies. First thing I take into account whether the patient is going for adjuvant therapy or not. If he has a chance of going towards for the adjuvant therapy, I invariably do a stoma and sit comfortably that nothing is happening down below, and we are safe from that point of view. Because if leak occurs or something, then the adjuvant therapy also gets prolonged, the time duration gets prolonged. Now, we have tried few cases of ghost ileostomy. Now, the problem is, it is easy. If you take out the loop, if you find signs of leak, you take out the loop. But what happens in the pelvis? You have to go in to drain the pelvis. And it is not so happy situation if you go percutaneously, radiologically to drain the pelvis. So ghost ileostomy, in my experience, hasn't actually helped, because if we find evidence of leak, invariably you have to go in, give a good lavage, good irrigation, and then if it is described, if there is less than 1/3 circumference gap, you can suture that one with momentum, it is there, and then form a ileostomy and come back. So that is for that. And another happy situation if you do a stoma is you can sleep well. Otherwise you need to watch the patient very closely for evidence of any leak, and slight pain and here and there, you think, is it a leak all the time, and you don't have enough radiological material to radiological way means to show you there is a minor leak or not. And if you do a CT scan, invariably you will find little bit of collection here and there. In early phases, you find there is no leak, you sit pretty, and 2 days after, patient goes for a frank leak coming back. So these are the issues to address. But as of now, I would say, as for me, if you are comfortable enough with your anastomosis and the bowel, the tissue is healthy, you can take a chance, particularly in benign lesions. Dr. Sastry, please.
Yeah, I may be a little more conservative and, of course, older also. Are we giving a perspective that as a diversion stoma is optional after an anterior resection, low anterior resection? I see, at least till now, our teaching has been that by default, a low anterior resection should have a diversion ileostomy. The emphasis is on indications where you want to avoid, not where you want to do. That has been our perspective. Am I too old in thinking in that manner? I am particularly conscious of, say, you do what you thought as a good low anterior resection, and there is an uncertain period. There is an ileus. There is no frank leak. There's no signs of frank peritonitis. An uncertain period where the patient has low-grade fever and ileus which doesn't settle. And when you do not do an ileostomy, you have a constant worry. And is a diversion ileostomy all that bad? is the morbidity really that much? I think these are the factors you would consider. And I tend to advise the junior people who just started their low anterior sections to do a diversion procedure as a rule, as a routine. Yeah, exceptions would be different. Say when you're, like you are saying, when it's a benign problem and you are very conscious of it, and the anastomosis is a little proximal, towards the peritoneum or above the peritoneum. And in anastomosis, which are distal, definitely you would like to do a diversion ileostomy. So these are opinions do differ. I think it's important to individualize a case, and my own opinion is that by default, the procedure is a low anterior resection with an ileostomy.
Yes, I agree with you, but I have small observations, not for your comments. One is 30 to 40% of these low anastomosis can show radiological leak. Radiological, not even they may not be clinical. Now, for that, we can't stamp that this is the proper incidence of anastomotic leak. If you exclude them, there is only 10 to 15% of cases where now it is dropping down, where you get anastomotic leak, particularly after the minimally invasive procedures. And if at all that happens clinically, we can take measures for that. For example, you can do a scopy and see the size of dehiscence or the mucosal ischemia like that, and then make the patient kneel orally and watch whether this is a small one, it's going to heal or not. If the condition deteriorates or the sepsis becomes more severe, you have all the option to go in and manage that. But the safest procedure for the students, I would agree what you are saying.
Yeah, I think we are going to discuss the
we'll move on, and we'll keep some of these issues for the open house also, where we can request the other faculty members to come in. I think we can move on to the next presentation.
Yeah.
Thank you,
The next topic is ileal pouch anal anastomosis and the problems. Well, the most common indications of the procedure are chronic ulcerative colitis that cannot be controlled by medication, and for patients with familial adenomatosis polyposis. We do not definitely do it in Crohn's. It is typically done in 2 stages to allow for pouch healing and for its adaptation, and to mitigate the risks of complications of a pouch anal anastomosis, particularly the leaks. Sometimes we even do in 3 stages when you're operating in acute colitis. Like many of the standard procedures, there may be a debate on a single or a 2-stage procedure, and we have Deeksha Kapoor here waiting to address this problem and give a balanced view of the solution, possibly with her own tricks to avoid the problems and selection of patients with an analysis of merits and demerits.
Thank you, sir.
Deeksha is one of the young but very energetic and enthusiastic and rare breed of a few female members of our group. And I got hold of her in, I think, one of the Jaipur surgical tutorial sessions, and she has contributed to some of the sessions earlier. And she was till recently at the Medanta, but I think a couple of months ago you have moved to BLK, is it?
Yes, sir. Just about a month.
Yes. Okay. Go ahead.
Thank you, sir. My slides are visible?
Yes.
Yeah, very well.
Please start.
So thank you so much, Professor Sastry and Professor Kapoor, for a very generous introduction. And I'm really grateful to be a part of this group. And we are having some great academically oriented discussions, and I really hope that it benefits the students. I'm sure to say that having to read for this has benefited me. So we are talking right now about ileal pouch anal anastomosis. Does it make sense to do it in a single stage versus a two-stage procedure, and possibly when? So like sir already said that we are going to do this procedure most oftenly for a diseased colon, and the most common recommendation for this would be an ulcerative colitis followed by FAP. Very unlikely that a single stage pouch, or even for that matter, the percentage of a restorative proctocolectomy being done for a Crohn's disease is relatively less. Whenever we are operating in a semi-emergent or emergent setting, we end up doing a subtotal colectomy, and that leaves us open with the option of either proceeding with a three-stage procedure, that is a subtotal colectomy followed by a completion proctectomy, a pouch, a stoma followed by stoma closure, or a subtotal colectomy followed by a completion proctectomy and pouch without a stoma. So we can have an option of a three-stage or a modified two-stage. But other ways to look at it is whether we are looking at three-stage, two-stage, or a one-stage procedure. One-stage procedure being the most uncommon kind of staging that's done. This is often the diagram which is shown on most website, academic windows, and textbooks, which is a very simplistic view of how a pouch is constructed. So for all of us who've actually done it or seen one, whenever we make the pouch, the mesentery of the small bowel is tethered posteriorly and inferiorly, and the room of movement for the bowel actually goes down. And the bowel is actually twisted a little bit to make or mature a stoma or an ileostomy in the right iliac fossa. So there are two things I want to point out over here. One is that the mesentery is fixed now, the room of movement is less. And to be able to make a stoma well enough, we end up moving a little more proximal than the traditional 20, 25, 30 centimeters from the pouch, so that it comes out comfortably and we are able to close it comfortably whenever we move forward for a closure. So this is a real life scenario, and this is not something that's written in textbooks, but this is what I feel actually happens. There are certain problems with a diversion stoma. So stoma-related obstruction, which can happen exactly for this reason, that the stoma has not been matured properly. There is a kink proximally. The proximal limb gets adhered to the anterior abdominal wall, the incidence of which is anything between 6 to 25% reported in various series. Stoma diarrhea, we of course understand it is possibly perceived to be a little more with a pouch patient than in another setting of an LAR and an ileostomy, simply because we are losing about 40-50 centimeters of bowel furthermore before we are able to mature a diversion. So the incidence being 14 to 25%, it is one of the most common causes of readmission following a pouch surgery. And needless to say that the dyselectrolytemia and the dehydration has a physiological and a financial toll on the patient. Following closure of the stoma, the incidence of small bowel obstruction, which is the most commonly and the most important trigger why a single stage pouch procedure was propagated, can be as high as 1 in 5 patients. Again, it is perceived to be a little more common in a patient who has undergone a pouch versus an LAR and stoma closure. It's been since 1978. This is probably one of the first series that was published by Professor Parks and Professor Nicholas of proctocolectomy without an ileostomy for ulcerative colitis, in which they showed technical success in 4 out of 5 patients, along with no complications. So the attempt to actually avoid a stoma is not something new. But can really the stoma be avoided is the question. So like I said, that let's leave the 3-stage behind. Whenever we are looking at 2-stage, we are looking at 2 ways at it. So the typical 2-stage is a restorative proctocolectomy with a stoma, followed by a stoma closure, versus a modified 2-stage, which is a subtotal colectomy, followed by a completion proctectomy and a pouch, and no stoma over there, and a single stage, which is a restorative proctocolectomy. So in 2019, in JAMA surgery, this retrospective study was published, which actually stated that the 3-stage procedure is probably overused for acute ulcerative colitis. And they said that one of the most important reasons that actually decrease the complications in a 2-stage procedure is the surgeon experience. And by multivariate analysis, the only thing that made a difference in postoperative complications. So whenever we are looking at downstaging a pouch procedure, we must understand what's relevant in which patient, what advantages do we get out of it, and what are the possible disadvantages to it. So this is a meta-analysis of 10 studies, about 1,700 patients, in which they said that the modified 2-stage versus a 2 or a 3-stage was equivalent in terms of anastomotic leaks, pouchitis, ileus, and small bowel obstruction. But whenever we are talking about studies or retrospective data in ulcerative colitis, one of the things we must be very observant of is the use of biologics. I understand that this systematic review is a comparison of 2-stage versus 3-stage and not 2-stage versus 1-stage. But I want to draw a certain point over here. So when they excluded patients or series in which the use of biologics was more than 20% was in more than 20% of the patients, both the procedures behaved equivalently. So the complications of a modified 2-stage actually decreased. So in patients with no biologics, it was actually okay to avoid a stoma. This was the meta-analysis figure in which it says that in pediatric patients, it favors a typical or a traditional restorative proctocolectomy and a pouch, that is, do not avoid a diversion stoma. Whereas in adults and in patients, basically in series in which the percentage use of biologics was less than 20%, a diversion could be avoided. So if we have to extrapolate this, in patients in whom biologics are not being used, possibly a diversion can be avoided. So this is another retrospective analysis which looked at 2-stage versus 3-stage, in which the total number was 212, and it said something very obvious, that the stage 3 is likely in all emergent settings, and there was no difference in perioperative complications, anastomotic leaks, pouchitis, or pouch failures in 2-stage versus 3-stage procedures. But let's understand why we want to avoid a diversion stoma. So there are some surgeons or some groups who will support the presence of a diversion stoma with a pouch. That is, if you do a stoma, you avoid a major morbidity. The consequence of an anastomotic failure or an anastomotic leak decreases. This was very well covered by Dr. Varshney. The anal sphincter is allowed to recover after a fresh surgery. So that is also supposedly beneficial. And one of the very important factors which I feel is relevant is that there is a psychological benefit of living with the stoma for some time before reversal. We must understand this is a quality of life surgery, and we are doing it for a disease in which anyway the patient is passing stools between 8 to 10 times per day. And even after the surgery, it's not that the incidence goes down a lot, but the psychological benefit of getting rid of the stoma actually supposedly makes the quality of life better for the patient. Then there are certain groups of surgeons who oppose a diverting loop ileostomy, stating that there is a reduction in the length of hospital stay, and the immediate use of an anal sphincter may actually avoid the development of a sphincter disuse atrophy. They also propose the evidence for this is questionable, that the risk of pouch ischemia is reduced. A proximal stoma will compromise the blood supply from a pouch. The problems of diversion ileitis may also be avoided, and the issues of small bowel obstruction post a diversion loop ileostomy closure are also circumvented. So is it actually possible to move away from a diversion stoma? This is possibly the most important evidence of literature that I want to emphasize on during this presentation. This is a recent meta-analysis published in 2023 in the Journal of Crohn's and Colitis, which looked at the data from 20 studies with the total number of patients 4,500, about half of which had not received a diverting ileostomy. So they said that when it comes to pelvic sepsis, if we look at the entire cohort, the forest plot, the diamond actually shifts in favor of a diversion loop ileostomy. So this shift was actually statistically significant. Similarly, with the rate of reoperations. So in patients with chronic ulcerative colitis undergoing pouch surgery, if there is no diversion, the chances of pelvic sepsis and the chances of a reoperation go up. But does that actually result in increased incidence of pouchitis or pouch excision, which is the traditional teaching? And it said no. The incidence of pouchitis or pouch excision did not go up even if the patient developed pelvic sepsis because a diversion stoma was not created. But the overall morbidity was not increased, nor was the rate of anastomotic leaks. So this was not found statistically significant on this meta-analysis. But there was a benefit in the rate of bowel obstruction in the long-term outcomes and a benefit in the incidence of anastomotic strictures in the long-term outcomes. Similar data was demonstrated in another meta-analysis which looked at data of only pediatric patients in a pouch with a stoma versus no stoma. And they said that the rate of leaks, pouchitis, small bowel obstruction were all similar. But the one fallacy in this was that the total cohort was 800 and the undiverted patients was actually very small, only 17%. Now, with ulcerative colitis, of course, we know that the bowel is diseased, but for a FAP patient, it's a polyposis bowel. It's not an inflamed bowel. So is it possible to actually do it in one stage? In this particular study, which is one of the large series of pediatric patients undergoing a pouch for FAP, it said that if the stoma was not made, it was associated with an increased risk of anastomotic leak and reoperations. But whenever we look at the data for a pouch surgery, we must realize that most of these series are retrospective studies. And most of these are single center data. In the meta-analysis that I showed from Journal of Crohn's and Colitis, which quoted data of 20 studies, about 16 of them were retrospective studies and 4 being prospective. Because of this, there is a huge selection bias. I guess everybody will agree that in a patient who is on a high dose of steroid or who has received biologics, one will err on the side of making a diversion stoma. Also, most of these studies come from high volume centers and not centers that are doing pouch surgeries on a yearly basis under 10. So although we do discuss about the learning curve and high volume concept when it comes to HPB surgery, for a surgery which is no less complicated, like a pouch procedure, we don't know what the correct volume should be so that the rate of complications go down. This is my last slide, and I just want to derive in the message that I personally will err on the side of doing a diversion stoma, at least for the next few years in my career. And if at all a seasoned surgeon is considering a single stage pouch, the absolute must should be that the procedure be done by a high volume surgeon in a motivated and counseled patient. The patient must understand what he's getting into, what are the possible consequences of the surgery and of the complications. The patient should not have been on biologicals before the surgery. It should be done in an elective setting. The surgery per se should be uneventful with complete donuts. In case during surgery, the surgeon is uncomfortable or there has been an unexpected event, one should err on the side of doing a diversion stoma. One may consider a single stage procedure if the mesentery is really fatty and the pannus is really thick and the patient is obese, because in that case, it is virtually impossible to bring the stoma out to the level of the skin. That is probably one of the few areas where one would take the chance in avoiding a diversion stoma. Additionally, there should not be any adverse factors that would actually give more weightage to performing a 3-stage procedure rather than a 2-stage procedure. So if you cannot really bring out a ileostomy following a pouch, maybe do an end ileostomy and stage it as a 3-stage procedure rather than doing it as a 1-stage. I would never recommend a single-stage procedure by somebody who has limited experience. In a patient who is poorly selected, it's not a decision which is made on table just by the whims of it that let's do a pouch without a diversion stoma. A procedure in which the surgeon has been uncomfortable and there have been some inadvertent events or unforeseen circumstances. And I think we all would agree that in a surgery like this, it is never sensible to please an adamant patient who demands that a diversion stoma not be done. Thank you.
Thank you, Dr. Deeksha.
Thank you, sir.
Good, wonderful exposition of pros and cons and the final conclusion. Your own personal, but I think it applies to all. Although you did hint about single stage or 2 stages for FAP versus ulcerative colitis, you didn't include it in the last slide. Maybe in that middle, you may consider, in an ideal circumstances, when you're doing for an FAP, you may consider avoiding ileostomy. Would you agree with that?
Yes. I agree, sir. I agree with that. But sir, I would also say that in extension to the comments you made after the previous previous presentation, I think at least for the next few years, I will always do a stoma, and I wouldn't recommend obviation of a stoma just because we are discussing this and just because there is a meta-analysis that says that it's okay to do it. I just want to include to what was said in the previous presentation, we often take a low anterior resection as a not so major or a not so serious operation. The anatomy, the vascular anatomy of the left colon, whether the IMA has been divided at the base or not, what is happening with the left colic artery, whether the blood supply is adequate or not, what extent of lymphadenectomy has been done, it's been done by whom. The rectum has been divided in 1 stapler or 2 staplers. I think a lot of these soft points, which cannot be actually given a number to, these intangibles are very important while making a decision whether a diversion can be avoided or not. So I think that same applies to something like a pouch. Unless it's absolutely, absolutely smooth, I think one should err on the side of doing a diversion.
Okay, Dash, you want to add?
Yes. As you are there. Any other faculty members? We still have a couple of minutes for this session. Dr. Rawat, you would like to come in and say something?
Sir, can you hear me?
Yes, Das, please go ahead. Go ahead.
It's raining very heavily here, so the thunderstorm. So, sir, I think I have no confusion regarding the management of the surgical management of a polyposis coli, where we are not definitely going to do a 3-stage procedure anyway. So the confusion is, or the debate is the management of ulcerative colitis, even not in malignancies. So ulcerative colitis, we tried to look at the results of the 3 steps through our thesis projects. We started with comparison of 3 stages versus 2 stages. And first 3 patients of 3 stages, single stage versus 2 stages. First 3 patients of first 3 stages, all 3 of them leaked and they went into sepsis. And 2 of them we have not been able to do anything till now. So we abandoned that. Then we continued the second stage as a prospective study. And we found in 60-70% of cases, 60+% of cases, there was pelvic sepsis, leak and a. So we also abandoned that one. Now we moved to modified 2-stage procedure. I think the advantage here is you are taking care of the disease in the first stage, then you give a gap where you are not giving any steroid or any immunosuppressants during that period. And I strongly believe that if you look into all these events, most probably in Indian scenarios, in our scenarios, the patients are taking steroid for a very, very long procedure, for a long period, and that is possibly making them vulnerable to all these complications. But these modified two-stage procedures also, we had 15% problem in these cases. And then we moved again back to the three-stage procedures. Particularly, the patient has a long-term steroid therapy in their management. So I would suggest that if the patient has long-term steroid therapy, and we have seen that infliximab, I think the monoclonal antibodies or the biologicals actually not harming so much as the steroids. And that has been proved by the studies also, that except only one biological, the other biologicals do not have any problem with the anastomotic results. That is what and second thing is, I just wanted to know, in the first stage, we do stoma usually on the right side. That's the end stoma. And the second stage, when you do a stoma, invariably you have to do on the opposite side. And the patient has two stomal openings and skin openings. What is your practice, Dr. Deeksha?
So we almost always end up doing a diversion stoma on the right side itself. So the previous stoma trophene.
I think Deeksha is also facing problem because of the storm. So, Dr. Rawat, you want to add something to this discussion?
I think I've done single stage a few times when I was in UK. But in UK, we will get the patients quite early. In the way gastroenterologists will refer the patient very early. But here, by the time you get a reference, you only do 2-stage or 3-stage. And like Deeksha has mentioned, that a patient is stable, not on steroid. My main thing is I always look at albumin, not on steroids. Patient is fit, then I will do 2-stage. Otherwise, somebody on steroid, I won't do 2-stage. Somebody who's got a quite an inflamed colon, colonoscopy showing pancolitis, patient is passing, a lot of blood in the stool. Those kind of things, I think it's safer to go for 3-stage. That's what my thing is. But here also, suppose if somebody patient is fit, then 2-stage. I have done one single stage here. That is the only one. I normally do 2 and 3-stage.
What about FAP?
FAP also, what I do, sir, is in the 2-stage, what I will do is, I will fire the stapler at a very low end and do the covering ileostomy, and then I'll make a pouch and then do it. Some of the patient who had a cancer, I know some of the surgeons will do 2-stage, but I normally because what happened is difficult to say what kind of cancer is it, whether it's T3 and above, whether the lymph node is present. You don't want to subject the patient having a pouch and then receiving a chemotherapy. So I'm bit of a though in the way that I'm slightly reluctant till I get a final biopsy, and then I will make a pouch.
Dr. Sastry, have you done or would you do a single stage either in UC or in FAP?
No, neither. I have always done either 2 or 3. Never a single stage.
I think the message is reasonably.
Patients what
Yes,
Dr.
Vaibhav, please come in.
Just an extension of what Rawat told, sir, because whatever literature we read is from Western world. And the patient profile, what sir mentioned in crux, the patient profile of Indian population is very different from what the literature we are reading. So in our scenarios, we need to err on 2 or 3 stage procedures more often, similar to that.
Yeah, at SCPGI also, and I think this is the experience of everybody else. Although all textbooks say that steroids should not be used for maintenance of remission, they should be used only for induction of remission. But somehow a large number of gastroenterologists continue these patients on steroids. So that itself makes a one stage definitely a no-no.
So because with all these risk factors, doing one stage is very challenging thing.
Yeah. So I would agree with what both Dr. Sastry and Dr. Rawat said, that for UC, one stage will be very, very rare. For FAP, it may be slightly more, but even in FAP, the more conservative surgeons would probably do a 2-stage, which means create a pouch and do a covering stoma. And once everything is all right, then close the stoma.
Isn't it interesting? The topic is single stage versus 2 stages, whereas the discussion is boiled down to 2 stage versus 3 stage. I think that shows the mood of the senior people here.
I have done single stage. But in the current scenario, the kind of patient you get, I won't do it. I won't do single stage. Very, very rarely. Like in UK, I've done single stage in FAP, I've done in ulcerative colitis also, but they are like elective, well-preserved patient,
Yes.
and they know the risk also, because you tell them all the risk, they accept the risk. I always tell them the risk of leak is about 10%, 5 to 10%. You will have a pouch failure, all those kind of things. If they accept, that's fine. But in some of the centers, they are doing single stage, but they are selecting the patients very cautiously, very cautiously.
I think we can move on, Dr. Sastry.
Yeah. Now the last presentation is Saumitra Rawat. Anastomotic leaks, colonic anastomotic leaks.
Yes, sir.
So I think that, if I can say in a sarcastic way, that is the icing on the cake, because that's what we've been discussing. I think 2 anastomosis which everybody is worried about. One is the esophageal anastomosis and other is the colonic anastomosis. So I think that's an important topic. Dr. Rawat, please. And I would request Dr. Obla to please keep noting down the points which maybe you would like to reiterate and re-stress. I think
Yes,
people
sir.
really are having problems with connectivity, because it seems Dr. Rawat has also got disconnected.
Sure, sir.
We'll wait. But we can continue the discussion what we were having.
I think one important
Yeah, Vaibhav, please.
One important thing is that whether to do a 2-stage or 3-stage or 1-stage and diverting stoma after LAR, it is an individual approach, sir. If the patient is high risk, then yes, a diverting stoma is necessary. And if patient is high risk, then a 2-stage or 3-stage procedure is on the card. So we cannot take a conclusion in a single line that this need to be done, but it is important to see on patient to patient basis what is the condition of the patient, what is the disease like, and what was the intraoperative findings, how the surgery went well, how the stapler fired, and then we should take a decision to make a stoma whether after LAR or after pouch surgery.
Yeah, and to that I would add what Deeksha said: surgeons' expertise and experience,
Yes, sir.
and the patient's perception, the patient's acceptance of a complication. See, when we talk to the patients, we know that this is a patient who's prepared for a complication and he won't react in a negative way. On the other hand, there are some patients who want things to go absolutely smoothly. So I suppose wherever there is a higher chance or risk of complication, patient psyche assessment and keeping that in mind is also very important. Of course, these days, medico-legal issues. So whatever we do, whether we do single stage or three stage, all this counseling, all this information has to be documented, and a good detailed informed consent is very, very important.
Yes, sir,
Yeah,
absolutely.
it's very true. I think it should be more emphasized. A shared decision making is crucial.
Sir,
Yeah, Dash.
sir, can we say that in ulcerative colitis, you shouldn't do a single stage procedure? And on the flip side, can we say that in polyposis coli, you shouldn't do a three-stage procedure?
Yeah, it is understood. I think that's been what the conclusion of our discussion has been. Three stage, there is no role at all in FAP. And for ulcerative colitis, two stage is the standard. I think that this should be the message in a master class.
So maybe we can continue the discussion because it seems everyone in Delhi, Das is connected, but Dr. Deeksha is also not connected, and I think Dr. Rawat has got disconnected.
So in Delhi, the thunderstorm is always patchy. Now it has gone from here. I am now in a clean environment, and I think it is raining there.
Yeah.
So it's raining. So I'm connected, but my video is off. It's raining.
So we can continue this discussion, and Dr. Naganath, maybe you can make some comments while we are waiting for Dr. Rawat to come back.
Yes, sir. Actually, our preferred method in pouch is we always do a ileostomy. That too, we do a turnbull's ileostomy, not a simple loop ileostomy, and we close it after 3 months. Because in public hospital, we have our own problems. We can't do the investigations as and when we require. If you are going to avoid the stoma, then you have to have all facilities to pick up the leak at the earliest and tackle them. So our preferred method is always to do a diverting stoma, the two turnbulls.
I think Dr. Rawat is back, so we
can... sorry, I don't know, there was some problem with the internet. I think it says host disabled participant screening sharing. So
we will do that. Don't worry. Himanshi, please, can you make Dr. Rawat co-host again? Actually, you got disconnected, so that's why.
Sure. Thank you.
Yes, please. Now you can share.
Thank you. Can you see my slide, sir?
Yes. Please start.
Yeah, thank you very much. Thank you, sir, for inviting me. It's such a great and healthy discussion. This is where we learn. Otherwise, we would have stuck to single stage and two stage. Although no one of us is doing single stage at the moment. I bring warm greeting from Sir Gangaram Hospital. This is my other affiliation, Christie's, where I'm a program director of international training program, and other affiliation is Royal College of Surgeons of England, where I'm a member court of examiner and laparoscopic trainer. So we all know, I think Vaibhav has made my presentation very easy. He has discussed majority of the point. I'm just going to reiterate, and I will make it faster when I see Vaibhav has already discussed. Colorectal anastomotic leak is a surgeon's nightmare. Any of the surgeons who are doing a colorectal surgery, anastomosis is the one which causes all the problems, because the patient mortality increases, morbidity increases, patient will require a reoperation, and patient relatives, especially when you are working in a private sector, they will be paying more and they will be asking too many questions, and it's difficult to make them understand that anastomotic leak, it will happen as long as it's happening in a kind of international things, and patient may need a permanent stoma. We all know if somebody had an anastomotic leak, they will have a worse oncological outcome. And the more important that is the implication for surgeon, whether they are using the poor technique or is the poor judgment, as we were discussing now, that if you are doing an anastomosis on patient whose nutrition is poor, whose hemoglobin is low, and who is on steroid, this is like a poor judgment. And then, like when I was in UK, all the surgeons are audited. Every year, you will have your mortality results, and you will have a anastomotic leak results. And if any surgeon whose mortality is higher than the national figure, then you need to go for retraining. One of my colleague whose rate was high, he went for a retraining for 6 months. So implication for the surgeons are immense. So obviously in UK, what it used to happen, they will give you a 3 figures. What's your anastomotic leak rate? What is the leak rate of other colleagues of yours in the same hospital? And third is the national figure. As long as your anastomotic leak rates are less than the national figure, that's what the aim is. And as you get trained more, your leak rate goes down. So this is the outline which I'm going to give. What is the definition of anastomotic leak? How to prevent it pre-operatively, peri-operatively, and post-operatively. And if you have a leak, how do you manage it? These are number of definition which has cropped up in last 40, 50 years. So as you could see, that there is no specific one definition of anastomotic leak. This is the one which is normally people are using: leak of luminal content from surgical joint between the hollow viscera. And this could emerge through the wound, through the drain site, or collect near the anastomosis, causing patient signs and symptoms. And the leak, in the absence of clinical symptom and sign, is recorded as subclinical leak. So this is again classification A, B, C. A is subclinical, B is minor, and C is a major leak where the patient have a peritonitis, sepsis, and if you don't take care of it early, then the multi-organ failure. This is a slide, anastomosis is like a marriage that, you need to have a good home-cooked meal. That means patient nutrition has to be good. There has to be a good blood between the husband and wife. So there has to be a good blood between the two bowels you join. There should not be any tension in the marriage. If there is a tension, you need to release it. So if your colon is not going down, you need to fully mobilize your splenic flexure so that at the anastomotic side, there is no tension. Like in marriage, you need to have a circle of trust. That the same thing in colocolic or colorectal anastomosis, that you should have a complete donut. And like in a good marriage, family issue stays in the family. And the same thing is colorectal anastomosis, that you do the leak test and there is no air leak. Leak rates are variable, and I will show you, I think this is one of the largest study done in Netherlands, where they had roughly about 17,000 colon anastomosis and 7,000 rectal anastomosis. So for the colonic, their anastomotic leak rate is around 7%, and rectal anastomosis is somewhere between 8 to 11%. So all the surgeon needs to know anastomotic leak is going to happen. But the most important thing is identifying it early and treating and managing the patient early. So how to diagnose? Clinical grade C, straightforward. Patient will be symptomatic. You'll get a CT scan and there will be fluid. Near the anastomosis, there will be gas as well. Similar thing is in the clinical grade B. In subclinical, that's where the thing is patient is clinically well and you do the test like some of the surgeon, they do it routinely and then you find the leak. There are some biomarkers. CRP is used by some of the surgeon in the Western world. They are using TNF alpha, IL-6 and MMP9, done in very, very few centers. As you could see, there is a study about the CRP level, and they say the cutoff level, if CRP is more than 135 on day 4, you will most likely, or there is a higher risk of a leak, you should go and check whether your anastomosis is patent or not. So why do the leak occurs? There is a patient factors, surgeon or perioperative factors and postoperative factors. I won't go too much in detail. I think Vaibhav has mentioned all these factors. Distance from the anal verge, male is more riskier. If the patient is obese, diabetic, or on steroid, immunosuppression, NSAID, or had a previous radiotherapy, or is alcoholic, malnutrition, chronic smoker, they all have a higher risk. And I think I'm not going to talk about the stoma. Vaibhav has clearly mentioned that that stoma leak rate is slightly less, but is safer if the patient had a radiotherapy or you are doing a multivisceral surgery, which also involves bladder hysterectomy, or if there is a presentation of fistula in the past. So these are the perioperative factor. Whether you are doing a stapling or hand-sewn, there is absolutely no difference. If you are putting a drain, it shows that there is a slight increased risk of leak if you are leaving a drain for long. Duration of surgery, intraoperative adverse event, intraoperative bleeding or blood transfusion, they all increase the anastomotic leak. If you are doing surgery on an emergency situation, if the patient has got an obstruction on bleeding, then also there is a higher risk, and multivisceral surgery, as I mentioned before. Preoperative bowel prep has not shown any difference whether there is a higher risk of anastomotic leak in colon. In rectum also, if you are, I normally don't give a bowel prep if I'm not going to make a stoma, but I will give a bowel prep if I have even slight inclination that if I am making a covering ileostomy, because I don't want to have a stool between my ileostomy and where I'm doing a anastomosis. Not testing for air leak increases your chances of anastomotic leak, which I will show you here. Once you have checked it, and if it is airtight, chances of leak is 4%. If it is a air leak and you do it, you close the air leak at the time of surgery, is 5%, and it is untested. The chances of anastomotic leak in one of the studies have shown to be 21%. What are the operative factors? Multiple staple for transection. If you use more than 2 stapler in the rectum, there is a high risk of anastomotic leak. If I am operating in an obese patient and if the rectum is thick, I would rather like to give a phenestrine incision and put a stapler so that I can staple it in 1 or 2 stapler at the most. I avoid going more than 2 stapler. Pouch or no pouch, or whether you are doing a end-to-end or side-to-end anastomosis, it doesn't make any difference. Both of them has got similar outcome. This is the rectal transection. These are a couple of studies. Higher anastomotic leak rate with multiple firing. If it is more than 2, there is definitely a lot of studies which shows that there is a higher risk of anastomotic leak. This is again, if you are using a ICG technique, putting a ICG in the proximal transection and after the transection. And they have done a pillar 2 studies where in 11 of their patients, they changed the plan. 9 of them, they did a proximal transection, slightly more proximally. And in one of them, they had to redo the coloanal anastomosis, and their leak rate was pretty good, 1.4%, and no leak in the above 11 patient where they changed their plan. This is the another one, SPY Elite system, which was used in couple of center in UK. This is only for extracorporeal anastomosis. And this is a paper from Oxford by Neil Mortensen group. This was a very early paper which showed that, if you got a good perfusion, your leak rate are nearly 0 or 1%. Post-operatively rectal tube, there has been some studies that especially in cases of anterior resection or low anterior resection or ultra low anterior resection, if you put a rectal tube or if you put a catheter, as you could see that they have done a study on randomized control study on 398 patients. Overall leak rate was 6.8%. Where they put the tube, it was 4%, and no tube was 9.6%. These are the other things which some of the surgeons have used, using a fibrin sealant or nitinol compression rings. This is about the reinforcement Gore SIM guard. This is similar to when bariatric surgery was done. They were using a seam guard on the stapler, both on the anvil and on the circular stapler on both the sides, anvil and end of the stapling shaft, putting a Gore SIM guard. And in this particular one, they found no significant difference whether you are using a reinforcement or not using the reinforcement. Now I am coming to the management of the anastomotic leak. Again, is subclinical, minor, or major. So if it is a subclinical leak, you can put a drain through the anastomosis, or you can put a fibrin glue. In a Western world and some of the center in India, they are using a endovac as well with good results. And this is about the minor leak. This usually happens, if patient is having a prolonged ileus, having a recurrent fever, pelvic pain, or sometimes, if you delay it further, then you are having a discharge from the vagina and rectum. So this is what happens if you got a tiny or contained leak. You can do a CT guided drainage. If there is no abscess or collection, you give a antibiotic and rescan. If it is a large leak, then you need to take the patient back to theater. If patient doesn't have a covering ileostomy, give a loop ileostomy, drain all the collection, depending on how much your circumference is involved. What I normally have it in my practices, if it is less than 1/4 of the circumference, I just leave it. If it is a total disruption, then it's a double barrel stoma you need to give, or you can, if the contamination is high. This is about the major leak. Sudden onset of patient will have generalized symptoms of tachycardia, tachypneic, and hypotension, fever, and patient is having a peritonism as well. Again, the blue shows whether the complete disruption is present or not. If there is a complete disruption in intraperitoneal, the safest thing is double barrel stoma, and you resect the anastomosis. If it is extraperitoneal, then you can do the end ileostomy, or if it is not a complete disruption, then you go lavage the whole thing and put a drain in and do the covering ileostomy. I will just present one of the patient. This is a video quite old. Had a LAR, 2 firing of stapler, found to have there was a leak, found to have a anterolateral dehiscence, which was less than 25%. And so defect was not closed, gave a covering stoma, pelvic lavage, and leave a drain there. So this is when we put a laparoscope in, you could see there is a collection there in the pelvis. I will just take it slightly further. It's just a 2-3 minutes video, just trying to separate the small bowel which is there so as to look into the pelvis, and looking into where the collection is, trying to push the bladder slightly higher up. That is where the leak was seen. It is anterolateral leak, less than 25% of the anastomosis. So first important thing is control the sepsis. So take out everything, give it a good wash. And once identified that there is not a full dehiscence there, and it's just the anterolateral, check the posterior also and the anterior. And then leave the drain there. So this is some of the non-traditional. That particular patient had a covering ileostomy, and then we reversed the ileostomy after 6 months, not after 6 weeks. These are some of the non-traditional technique. Endovac is one of them, and this is where you put the endovac in the cavity, and normally you leave it for 3 to 4 weeks. It depends on when everything settles down, and it is best, if it is applied early. If the anastomotic leak you can catch early, and you put a suction drain there, and there is a 95% success rate. Another technique is putting a temporary stent, but not many people are using it because there has been few studies that, it's not working well. Some of the gastroenterologists, they are putting in an endoclip or beer claw where the anastomotic defect is. I think these are some of the myth of the anastomotic leak, that all leak needs a operation. They don't. And all leak with the reoperation require dismantling of anastomosis and giving is permanent stoma. And this is again a myth that there is no role for laparoscopy. And another myth is on day one, it can't be leak. And another myth is their bowel is working, so it can't be leaked. These are the myths which we should not go for. I think the most important thing is, as Vaibhav has already mentioned, that we need to optimize the patient preoperatively, and the surgical operator need to see exactly what is needed out of the patient. And the quality assurance is very important, that you need to do the audit. This is our audit which we presented in SAGES. These are the surgery which was done by my juniors who were clinical assistant or final year PGs, just to make sure that their results are similar to what I am or better than mine. And this is a fellowship which we started in colorectal surgery with the Christie's Hospital. In summary, leak are bad. I think the most important thing is prevent the leak, optimize your patient, optimize your surgical technique, discuss with your colleague. And I must say that this is a great forum where all of us are sharing our point. And I think, as other colleague has said, that give a stoma to the high risk. And what I always believe in, if the patient is not recovering the way you like to, I think you need to investigate the patient sooner. If patient is having a ileus or patient is slightly tachycardia, because diagnose your leak early and manage your leak early. This is the most important thing. It's a teamwork. That's the team from Gangaram. And Dr. Kapoor, thank you very much for inviting me. The greatest accomplishment of man has resulted from transmission of idea and enthusiasm. And your Jaipur forum is great, and so is AIG, where we share our ideas, and we all are enthusiastic about teaching and training. Thank you very much again for inviting.
Thank you, Dr. Rawat, for your kind words, and we will be very happy to have you again and again in these online sessions. Over to you, Dr. Sastry and Dr. Das, for the discussion. We can have a discussion on the Dr. Rawat's presentation, and then we can have open house session where Dr. Naganath maybe can start the discussion.
It's a wonderful presentation, Dr. Rawat. You very clearly laid down the guidelines and what is new. The vascularity, I just have one question. Although you referred to the how important is vascularity, the ICG, which was mentioned in the earlier presentation, and Vaibhav was saying you use in all the patients. Whereas yesterday there was a presentation and where the evidence was shown to be not too much in favor of ICG. What is your take on ICG, which is the in thing these days in GSSG?
What we are doing, sir, is two of my previous PGs. What we are doing is we are doing a thermographic, this like a mobile phone. And what we do is look for the temperature. So I think it is working well for us. Since that our DNB student are doing, we look at the change because it detect whether there is a vascularity at the at the edges where you are doing a anastomosis. See, it is individual whether it's working or not. I'm not using ICG much, but this one, which this is where we are using, it has been accepted for publication in one of the journal, and I think this is a device which has been uh, made by one of my friend who is based in America. He was from Maulana Azad. He was a professor in Philadelphia, and then he did his MBA from Wharton. So this is what he has come out with, and we are finding it very useful. We are finding it useful in, I would say, 1/3 of the patients. We are, uh, making changes in where our anastomotic line is to be. We are making changes, sir. Eventually, it all depends on what is working best in individual hand. That is what I always believe in. If somebody is doing it the way they are doing it, as long as leak rate is less than, say, I would say 5%, that is what it is, sir.
But Dr. Shastri, my comment on ICG debate or controversy which you asked is that it's something which will do no harm. It's simple. I don't think it's very expensive, although I have not used it myself. But if it shows that there is a problem with the vascularity, you then and there you have an opportunity to take some measures to revise it, refashion it, as opposed to handling a leak later. So I see no reason, even if the evidence is not there, that if you can use it, you should probably use it.
Sir, one thing,
Yes.
you mentioned this, it's not a costly drug. Drug is not costly, but the equipment, the laparoscopic tower with ICG facility, if someone doesn't have from the beginning, they need to procure it. So that is a costly affair. One thing. Second is because we are doing in our institute, it is kind of a problem solving tool. If you can see the vascularity is good because you are experienced for last 30 years, you are seeing the bowel, whether it is devascularized or not. But in some cases, when you are dicey, whether it is actually vascularity is there or not, then in those cases, yes, it sometimes helps you out yet that the end of the where you're going to the anastomosis is well perfused or not. Similarly, in colonic interposition, when we are doing when the colon is reached to the neck and we find that mucosa is slightly not good or it is not, in those cases, yes, ICG is beneficial that you can, after doing the anastomosis, you know that it is well vascularized, perfusion is good, and then you can sleep, take a good sleep at the night. There's nothing going to happen. So I think in that way is useful, sir.
I think our results, they are not, I would say that it has shown a lot of changes in the anastomotic leak in a control and after we have done it. There is a, I would say the changes is about, I would say the patients it's in a single digit. But then also, I think you sleep better. That's what I would say. That, if I've done an intraoperative infrared thermography, and it is a very simple tool, it's on the mobile, you just put it on the bowel. And obviously, if you are doing a colorectal anastomosis, because we do it laparoscopically, we can't put it inside the tummy, but the proximal part of the bowel, that is the most important thing. And what I have also done previously, when I started, I was taking IMA just at the origin. What I have also started doing is this: I try to preserve the left colic if possible. That is what it has helped me, because I would say that we haven't had any mortality in colorectal cancer. We would have, I think, 3-4 leaks in last many years. Vaibhav has worked with us for 1.5 years. He was in Gangaram. And I think the thing is, do what works for you. What works for you. I think a lot of my clinical assistant and registrars, they say, sir, why you are leaving left colic? I said it works with me, because if the left colic is there, and if I don't find any macroscopically, with my eyes, there is no node at the origin of IMA, because for initial 6-7 years of mine, I have divided IMA absolutely at the origin. I will just leave 1 centimeter of the cuff on the aorta. And then I think with time I'm leaving left colic. And I think in last 4-5 years, we didn't see any sort of leak or anything. Right colon, yeah, we had 1 or 2 leaks in last 1 to 2 years. But then I think what works best for particular person, if it is working well, I won't change.
Dr. Naganath, maybe you can start the discussion. We have another 20 minutes. Yes.
Sir, can I share my experience?
Yeah, quickly, because then we need to give time.
Yes, sir. I tried here. We not the ICG, but fluorescent yellow dye we used, and then I found that if you are doing stoma, then there is no difference between whether you are trusting your visual impression or do a dye. If you are doing a stoma by default, what Dr. Sastry says. And second, when we are doing a colonic pull-up, or where I do get a chance not to do a staple but cut the bowel, you just cut the bowel at the end, like the colon pull-up before doing anastomosis, incise it by using a scissors, a knife, see good flow of blood. That's enough for knowing the vascularity of the conduit. And now, of course, we are doing a study that in comparing the fluorescent dye with pricking near the staple line where we're going to do anastomosis. We do prick with 22 size needle and see the color or the flow of the blood. If it is there, what is the result? It's too early to say the results to you.
Yeah, Dr. Naganath.
Yeah, thank you, sir. So at the outset, I would like to thank you for inviting me to this forum. And all the presentations yesterday and today were comprehensive and resourceful. And I also learned a lot of points. Actually, to begin, regarding today's this thing, regarding Dr. Vaibhav's this thing, he has covered everything well. I would like to add one thing. There is something called tube ileostomy with biodegradable material. That's also useful to avoid, ileostomy. And then, as Dr. Rawat said, if you can use colo shield or some interluminal stents, and then we can avoid stoma. But all those things are not 100% foolproof. And he also mentioned the ghost ileostomy. I don't know how many people have done that ghost ileostomy. And we all know that the stoma is a disability. Apart from causing physical morbidity, it causes more of psychological morbidity to the patient, impacting the quality of life. So that's why everyone wants to avoid the stoma. But if you want to avoid a stoma, then one has to be very careful to pick up the leaks at the earliest and tackle it. And I feel after LAR for cancer, we should always do a covering stoma, because the problem is the vascularity of the distal stump. Proximal stump we can always verify. Distal we are going to staple, number one. And number two, in teaching centers, multiple team operates. one team will resect, one team will do anastomosis. And another thing at the end, it is the gut feeling of the surgeon. Even though the donuts are intact, the leak test is negative, still it can leak. So at the end of the thing, it is the surgeon's gut feeling also plays a role. If he's not happy, if he feels something not correct, then it's always better to go in for a trauma. And yeah.
Yeah, please, you carry on.
Regarding Dr. Deeksha's this thing regarding the single stage, 2 stage, and 3 stage, my this thing is everyone said for FAP one can do a single stage, but how do you know that there is no malignancy in FAP? Supposing if the biopsy comes as malignancy, then what will be the treatment? Whether we should do a 1 stage or should we do a 2 stage procedure, a 3 stage procedure? So I want to have the opinion of other faculties. And regarding this diversion following the pouch, everyone talks about stoma ileostomy, but what ileostomy is ideal? A simple loop ileostomy, divider loop ileostomy, or a Turnbull's ileostomy, because sometimes if there is any distal problem, the pouch related problem, you may have to leave the stoma for a long time. In that case, a simple ileostomy may not function. Maybe after 6 weeks, it will lose its servicing and it will not function. So these are the areas I just wanted to touch on and invite the comments from the other faculties and also students.
Yeah, Dr. Das, Dr. Shastri.
Dr. Naganath, Babu, I do not understand how a missed malignancy in FAP and ileostomy or no ileostomy, how they are connected. A single stage or a 2 stage, it doesn't really matter there when you have an unrecognized malignancy in the edge of an FAP. I don't think that is a factor at all. If you have a standard protocol of doing a 2-stage procedure for all IPAA, the pouch anal anastomosis, then it is fine. Otherwise, you have certain indications, say for an FAP, obviously you would be looking for a polyp at the edge and a suspicion of a malignancy that you would be counter-checking before you embark upon any surgery. So that may not be really a factor there.
Supposing there comes as malignancy, you may have to give adjuvants, no, sir? Then in that case?
No, that's exactly what I'm saying. Say if you have a pouch already made, there is no other way. You cannot escape from it.
Okay. But if we anticipate such things, then there is a role for doing a diversion. Okay, then next is which stoma is better?
Can I comment on FAP? I think in a FAP, a good colonoscopist normally, can make it out which area is looking suspicious. If it is a small multiple, then it's okay. But if any of the area looks slightly suspicious, then it's a different ball of game. It's different ball of game. It's different ball of game.
Then regarding the stoma, which is preferable, a simple loop stoma or a Turnbull's?
Okay, I will address that. I think then no study to say which one you should do. What is written in the textbooks is when we do a loop stoma, it has 2 parts. One is a different part. One is little bit protruded, one is little bit shallow. So invariably what happens with the effluents come from one side and small amount they start going into the other side. And if you see the pouch patients or the where you have already done a stoma or the low anterior resection patients, After about 15 days or so, they will say, even some people after a week, they will say that I'm passing some amount of stool down below. So they are not complete diversions when we are doing it. So my suggestion is, if you're really thinking that the anastomosis is really risky and patients is not very fully optimized, then better to go for a uncut route. I have done in 2 patients, and day before yesterday I restored one of them. So uncut means you make a hole in the mesentery and using a TA stapler, thoracic anastomosis stapler, just staple it. So theoretically that should work well. What is written in operative surgery is to avoid that shallow versus the effluent going into, to avoid effluent going into the efferent limb, ultimately downwards. What you can do is you can do a omega loop. So if you do a omega loop, the chance of going into the distal limb is theoretically not there. But constructing a omega loop has its own problems, post-operative complications like rotations, adhesions, and ischemia. So I think if you're not very happy with your anastomosis, better to be on safer side. And the patient has multiple medical risk factors. That is also very important if you're going for a re-exploration very quickly or second time. Then better to go for a uncut loop stop.
Next thing is, we are talking so much about whether to do a stoma or not. Do you have any scoring system? So most of the thing what we do is only subjective feeling. And do you have any objective scoring? In the literature, it's not available, and even if it's available, it's not validated. So what is your take on these things?
See, if I am to answer that one, there is no objective scoring, and it is practically not possible because there are so many factors, and objectively to measure those factors, like for example, if you are doing a low anterior resection or ultra low anterior resection, how to objectively say that that is good or not? It's beyond your visibility. One Japanese study says that you do a scopy and see for mucosal ischemia, or if it is blue, then they delay the oral feed, or they go for the ileostomy, which they have extrapolated from the cervical esophagogastric anastomosis. They routinely do that. They do a scopy on the table and next day, and take measures like that. So if we have to score this, we have to take maybe about some 30-40 points and then calculate and validate. Yes, there is a theoretically you can go for it, but as of now it is not there.
Yes.
It can be a research thing.
Yeah, can I just comment on that? Previously I was giving ileostomy only on ultra low, but what I am doing now is I'm giving a ileostomy on anyone if I am cutting the pelvic peritoneum and going between the vas and the rectum. So this is what I have. It's a very simple, if you cut the pelvic peritoneum and if you are separating the vas, separating the seminal vesicle from the rectum, I will give a ileostomy. Dr. Nandi gives ileostomy in almost all the patients of rectal. But what I do is if I go below the pelvic peritoneum and if I am going between the vas and the rectum and going lower down, previously I used to only do in ultra low, but now, and it's working well. It's all depends on what you practice.
Yeah.
And if it is anything, if I have a anastomosis above the pelvic peritoneal line, I don't give any anastomosis.
So one thing is, if the mesocolon is very bulky, for example, and you're going for a staple anastomosis, would that be a factor for you to consider for stoma?
See, as you always said that, there are so many factors. if you have, intraoperative event, if you got a bulky mesocolon, or if you got a very, very large mesorectum, and if you have fired 3 stapler, also if it is a narrow male pelvis, where you are not having a good visualization, and if you are there is a donut, and donut is complete, but you are not happy with the thickness of the donut. So there are so many factors. I think with time, with the experience, you know what where you will give a stoma or where you won't give a stoma.
So one way to go about it is what we are thinking at one point of time, that we know what are the risk factors for increased anastomotic leak. There could be some major factors, some minor factors, and then you give some point to the major factors and some point to the minor factor and see how it is going about. But it is so extensive and each one has so many variables to document. At least 25% of them is very difficult.
So it's
And-
better to
and-
have the lowest threshold to do a stoma if needed. Now, next thing is I would like to know from you regarding the anastomosis, how to check. Usually we check by air leak test. Now, is it useful to use a colonoscope to inspect the anastomosis and see the mucosa also? Is it really going to be useful or not?
I would say a lot of surgeon, they put a colonoscope in UK. A lot of surgeon put a colonoscope in. I used to do it in some of the patients. And putting a colonoscope, if you put it gently and not pushing too much of a air, because you don't need to go all the way. You just need to go to the anastomosis and that's it. So it is not detrimental putting a colonoscope in. And other thing I will share with my experiences, like in UK, 1/3 of my patient will be obese. In obese patient, although we say the risk of anastomotic leak is higher, but I will, if possible, if I am happy with the surgery, in a obese patient, I will be very reluctant to give a covering ileostomy. Because giving a covering ileostomy in a obese patient, because majority, or I would say majority of mine is laparoscopic, I would like patient to be up and about in on day 1 or maximum day 2. And what I have found out in obese, once they are up and about, obviously there will be a risk of anastomotic leak in 5%, but their quality of life is much better if you don't give a stoma, because there is a problem with their tummy bulging, and there is a lot of problem with maintaining a stoma. So this is a paradox where, although the obese, we say there is a high risk of anastomotic leak, but I usually avoid giving a covering ileostomy in obese patient. In those patients, what I do is I put a Foley's catheter just above my anastomosis and flush it 3 times a day or 4 times a day.
Then
Will you retain the Foley's catheter or you'll introduce then and there?
So I will introduce at the time of surgery. When you are, because when you put a laparoscope in, you see the Foley's also. And obviously, you want to make sure Foley's hasn't gone through your anastomotic line. So I'll put a Foley's and fix it there. And yeah, I don't routinely use Foley's, but in few selected cases, I do.
Because somebody injects the balloon at the level of anastomosis, then that can cause damage. So what about the Baker's anastomosis? How many people prefer Baker's over end-to-end anastomosis? Does it impact any this thing leak?
So we have 2 more minutes. So any concluding remarks from Dr. Shastri and Dr. Das?
Sir, not a concluding remark, but Western countries, they do scopy almost for all anastomosis except small bowel to see that, but that is counted as a procedure, and the cost is also uh, put on that. But we have now enough evidence to say that if you do a anastomotic testing by using either air or air, there are studies comparing air versus water versus betadine, which they say yes, yes. So if you can establish that there is no leak by inflation study, then the result of the anastomosis is very good, and that has been shown by studies. The scope actually in rectal anastomosis hasn't changed the management as like esophagogastric anastomosis.
Can I just comment? In a Western countries, they are doing a colonoscopy on a left-sided anastomosis. They are not using it for right hemicolectomy. No, they are not. It's only for the anterior section or sigmoid colectomy they will use,
Yes.
not for right hemi or extended.
No.
Yeah, because you said all the colonic.
No. I meant all except the small bowel, and the right hemicolectomy includes small bowel.
No, you didn't. I thought you mean all the colonic.
No.
You said on the
Shastri.
left side.
Dr. Shastri, any?
Yeah, I think we had a wonderful discussion of leaks in coloanal and colorectal anastomosis. By and large, we have agreed with the standard principles which are agreed upon, although there is a mention of avoiding a stoma and what are the circumstances where you consider avoiding a stoma in a low anterior section. Particularly, as Dr. Rawat said, in an obese patient, fortunately, we don't get that kind of patients here, where an ileostomy is likely to, may not be really flush or like a nipple, and then if it retracts, it'll be quite a bad thing. The morbidity of an ileostomy which is sunken is bad. So we must have an open mind there. But by and large, we have agreed that any anastomosis which is below the peritoneal reflection, which is low anterior section, as a routine, we would consider a stoma. The IPAA, again, a two-stage is a standard procedure. A single stage is generally not preferred, but then in a FAP, we may consider in an ideal circumstance where you have a very good anastomosis, and you might consider doing a single stage. And anastomotic leak, all the various grades of leak, it's important to grade the leak and then have an expectant management and identify the gross intraperitoneal leaks and don't lose time in re-exploration, either laparoscopic or open. These are the issues which we have discussed, and I think by and large we have agreed upon.
I think there is
yes, please.
There is a comment.
Dr. Sitaram wants to underline the statement made by Vaibhav that we should be very, very cautious in following the Western guidelines when dealing with Indian patients, because there are so many factors which may be different. So I think that's
I think it's absolutely crucial. That's what I'm saying. I won't do single stage in Indian patient. I won't do single stage ileal pouch anal anastomosis. I won't. And I think Dr. Sitaram has said it absolutely right. And this is what you should do. And as Professor Nandi always say, think global, act local. this is what should be done. We should not be going and reading the American and European paper and start practicing. You need to think Indian.
Thank you, everyone. We half a minute because we have a tradition. At 7 and close at 9.
Actually, I wanted to conclude with this. There are usually 3 questions asked to me in my round by the students. So to complete this, if you can answer these 3 questions. One is they always ask after low anterior resection, if you're not done a stoma, when to start orally. Second, they ask whether to do a contrast study routinely in this patient before starting orally. Third, if there is a radiological leak but no clinical leak, then what to
do? Quick answers. Who will take that?
I think the first question is I will start feeding pretty soon. I don't like to keep NG too much. If it is say 100, 150 or less than 100, I'll take the NG tube out. I take the drain out also early. And because if there is a leak, you would know. And if it is a radiological leak, then you become cautious. Then if it is a radiological leak, then obviously you would like to keep the drain in, because what I feel with the advent of intervention radiology, even if there is a leak later, it doesn't make much of a difference whether your drain is there or not. Some of the time, patient has got a leak and drain is not draining that leak. So one was feeding, sir. Second was radiological leak. If it is a radiological leak, then obviously, you will see.
Should we do contrast study in all cases?
I don't do.
I don't do. We will need to.
I don't do.
So just
Thank you, sir.
I do it if I've done a esophageal surgery or total gastrectomy. That is the only place where I do the leak test. Where I do the contrast study, I don't do it in anterior resection, but I've got a low threshold. If patient is in ileus for 3 days, or if patient is not progressing well, I won't wait too long. I will do the study sooner.
Deeksha, half a minute, but that I'll say that if there is a doubt, instead of a contrast study, do a proper CT, because more important is to see whether anything is collecting inside. Deeksha, just half a minute. We need to close.
Last one comment. If we are not doing a routine contrast study, sir, then I don't think there is a question about a radiological leak.
Yeah. Because, sir, if you are doing a CT scan to look for radiologically, that means the patient is sick or patient is not doing well.
Yes.
So means something is wrong.
Yeah.
Thank you.
With that, I would like to thank all the speakers and Dr. Sastry and Dr. Das for agreeing to moderate this session. And I'll keep everybody informed about what is the progress as far as how many students and surgeons have watched the uploaded videos. And thanks to team of Dr. Avinash Tank in Dwarika Hospital in Ahmedabad. Thank you all very much. Thank you, Dr. Naganath, Dr. Rawat, for joining us. Thank you.
Thank you, sir.
Thank you, sir. Good night.
Good night. Good night.